So, part 2 of our airway disease. This is not a mixed-up question. So, basically, the patient here is a patient comes to the hospital, history of smoking with 60-pack years, homelessness, non-adherence to meds, generalized psychiatric disease. The patient has a history of COPD but never got PFTs, and really presents with dyspnea. All right. So this is not an uncommon presentation in the hospital that you have a patient who has a long-term diagnosis of COPD, but you really don't have the gold standard diagnosis of COPD because you don't have a PFT. So you don't really know if they have an obstructive deficit. And you're kind of stuck thinking, okay, is there dyspnea from a COPD exacerbation? Do they have COPD? Or is there dyspnea from something else, like heart failure? And really the big thing here is going to be history physical and looking at their previous imaging to see if they have a long history of COPD. Everything here really does have, I'll go to the next slide where it has most of it, but it has its own likelihood ratio. And what is a likelihood ratio? Positive likelihood ratio is sensitivity over 1 minus specificity, and a negative is 1 minus sensitivity over specificity. How do you use likelihood ratios in your clinical reasoning? You don't have to memorize them, but it is good to know the likelihood ratio in general of things that we do on physical exam and how they impact our post-test probability with that exam being the test, right? So in general, so going through pre-test and post-test probability, someone has a positive likelihood ratio of 10, you take your pre-test probability and you can increase it by 45%. So say if your pre-test probability is 50%, you're like, I don't know if this patient has this disease, doesn't have this disease. If you have, let's say, an imaging or a test with a positive likelihood ratio of 10, that's going to increase your probability of that disease by about 45%. 5 increases it by about 30%, and 2 increases it by about 15%. Next is negative likelihood ratio. So if something has a negative likelihood ratio of 0.5, that'll decrease it by 15%. So it decreases by 15%. So say you say 50-50 shot, this patient has this disease, the negative likelihood ratio is 0.5. If the negative likelihood ratio is 0.5, you can decrease your probability of that disease by about 15%, around 50%. 0.2 reduces it by 30%, and then once you have 0.1, that's a high negative likelihood ratio. So if you have a test or whether it's a physical exam feature or some sort of imaging or procedure that has a negative likelihood ratio of 0.1, so you're at a 50% probability of the disease before you do that physical exam or before you do that imaging or procedure test, that would put you at negative 45%. So you would have 95% probability that the patient does not have that disease. So not every physical exam feature, not every procedure is created equally. They all have, like, just remember, medicine's art of probability and a science of uncertainty. So each exam feature comes with its own probability of it and how much it increases or decreases the underlying disease, the probability of the underlying disease you're looking for. So all these test features here are going to have their underlying positive here, let's say on this first one, and negative likelihood ratios, which would increase or decrease your probability. And it's basically, this is really a cornerstone of clinical reasoning, and shows that you just can't hang your hat on any one feature. You really have to look for multiple features. So approach COPD with likelihood ratios. If you don't have the gold standard COPD, first thing is history, right? So a ton of people come to the hospital, they have a 5-pack year history of COPD, of smoking. Really, if they have that, that's going to be unlikely that they have COPD. I know in other countries, in places where they have indoor fires, then smoke inhalation from that's another thing that can cause COPD. But if they don't have a history of living in other areas for a very long time, or they have less than a 15 to 20 pack smoking history, it's very unlikely to have COPD. Most patients with COPD are going to need to really have a greater than 40 pack year history. Now this can change a little bit. There is a genetic predisposition to the development of COPD. Women also develop COPD easier than men, which is why there's some lenience from 20 to 40 pack year history. But once you see about 40 pack year history, that's very likely the patient has underlying COPD and has a likelihood ratio of 8. All these likelihood ratios, I think, we're taking from the book McGee. The book by McGee is Evidence-Based Physical Diagnosis. Next is going to be what you're going to find on the physical exam. And I kind of put this into 3 separate categories. You're looking for obstruction. Some patients with COPD will have hyperinflation. And you're looking for signs and symptoms of emphysema. So first is going to be obstruction, right? So what you kind of do is have the patient not against pursed lips. You will have the patient breathe out, right? So you'll ask the patient breathe out an entire breath. So you take a full deep breath, breathe out an entire breath. You're going to listen basically over their neck, and you're going to see how long it takes those patients to get all of the air out, right? So it takes 9 seconds. Luckily, that this patient has some sort of obstructive deficit, so it could be COPD, molecular ratio of +4. If it takes less than 3 seconds, this patient don't have obstructive defects, or very unlikely, and has a negative molecular ratio of 0.2. So definitely something, outpatient. Hard to do inpatient because most patients will cough if they're during a COPD exacerbation, but something you could do outpatient to see if the patient may have COPD. And it has pretty decent test characteristics as well. These patients, COPD, remember they have dynamic air collapse. So, emphysematous COPD, they get rid of all these alveolar air sacs. Their alveoli are less elastic, so they're unable to generate a sufficient amount of pressure. Also, they may have some inflammation going on in their airways, more of the chronic bronchitis subtypes had increased airway resistance. So once they have a hard time getting the air out, one, because they have decreased pressure in their alveoli, but they also have a difficulty getting out because they may have increased resistance in their airways from chronic bronchitis. No matter what they do, so say they use their muscles of respiration to get the air out, and they force a lot of they use a lot of pressure to force that air out by using their extrapulmonary muscles, and really try to take a deep breath out. They can still only get it out at a certain quickness, because not only does this collapse the alveoli to get the air to help force the air out and increase pressure in the alveoli, it also leads to dynamic airway collapse in the bronchi. So the bronchi get hit with that pressure too. If the pressure is too high, they're going to collapse as well. So the patients are really stuck at a specific FEV1 because if they put too much pressure in the lungs with their extrapulmonary muscles, they'll collapse the bronchi as well, giving them more obstruction. So that's kind of that dynamic airway collapse and why their FEV1 is kind of stuck where it is. And this is the poor man's FEV1 by doing a forced expiratory time. Next is going to be a wheeze, right? So when those airways get closer together, they can vibrate, causing wheezing. Not the best, but somewhat helpful, mostly for chronic COPD, say in the outpatient, not during COPD exacerbation, has a positive molecular ratio of 3 and a negative of 0.5. Another one is pursed lips. So these patients, once again, they get that dynamic airway collapse here. So sometimes they will increase the pressure at the end. That'll increase back pressure to pursed lip breathing, increase back pressure in the bronchi, increasing pressure in the bronchi, decreasing the likelihood of collapse. So pursed lip breathing is something you might say. And another one is going to be early inspiratory crackles. So with these patients, they have these really inelastic alveoli, and end of expiration, these inelastic alveoli may collapse. And with pretty low pressure, once they start breathing again, they may pop open. And when they pop open, because it's low pressure, because they're inelastic and really, what's the word I'm looking for? Inelastic, lowly compliant alveoli, then we're going to pop open early with low pressure, which leads to early inspiratory crackle. So actually finding early inspiratory crackle on exam gives you a positive molecular ratio of 14s. It's really the only thing, obstructive disease is really the only thing that produces that early inspiratory crackles. Everything else is going to be mid to late. Next is going to be looking for signs of hyperinflation. Big one that can be helpful is looking for laryngeal height. So here's the Netter's pink puffer. Here's the patient's laryngeal height. You measure laryngeal height from the patient's suprasternal notch right here to the top of the thyroid cartilage. Now, in patients who have hyperinflation, clavicles are going to come up. The clavicle is going to come up, it's going to bring your substernal notch up, and that's going to get closer to the patient's thyroid cartilage. So if this area here, if it's hyperinflated and clavicles and the substernal notch are increased, if that area here is less than 4 centimeters, that means the patient's likely hyperinflated, and that has a positive likelihood ratio of 4, but not a great negative likelihood ratio. So helpful is there, not helpful is not there. Lastly, it's going to be signs of emphysema. I'll use the imaging to kind of go over this. So emphysema, they're going to have destruction of those airways, destruction of the alveoli. Destruction of the alveoli is going to decrease those alveolar breath sounds. So if you get diminished breath sounds, that can help. Though other things that can diminish your breath sounds would be like pleural effusions, even severe obesity. You might not be able to hear it to the chest wall as well. But if you hear diminished breath sounds because of alveolar destruction and decreased alveolar breath sounds from that, that can help. And lastly is if the patient has a decent amount of emphysema, too, tapping on the right upper chest wall, like right around here, and hearing hyperresonance from that decreased parenchyma and increased air within the lungs can actually give you a decent positive likelihood ratio. So helpful if it's there, not sensitive enough to give you a good negative likelihood ratio, so it's not specific for that. Lastly, look through their current previous imaging. If their chest x-ray is hyperinflated, that's helpful. Once again, specific but not sensitive, so it's not there, it's not helpful. But if it is there, you have a positive likelihood ratio of 4. So you can see here, you can see many ribs, you can see blunting of the, not blunting, but you can see flattening of the diaphragm here as well. And looking for next, if they have a previous CT, definitely look at it and look at the upper airways. Do you find emphysema there? Especially if they have not a lot of people won't have this, but they have inspiratory and expiratory scans. This can even increase the testing characteristics of looking at a previous CT. So if you don't have PFDs, these are really the history, physical, and imaging ways to increase or decrease your probability that the patient has underlying COPD, which may help you on the hospitalist, so may help you on admissions. For a patient with dyspnea, see if COPD could be COPD or COPD exacerbation could be contributing to their underlying disease, and not just solely relying on wheezing, because you can see wheezing in COPD, asthma, but also other diseases as well. Even cardiac can give you, even cardiac disease can give you edema in your bronchi, with bronchial narrowing, and then subsequently vibration with breathing out. So even cardiac wheeze could be on your differential. So not all that wheeze is asthma or COPD. So I think it's helpful to know some of the other history, physical, and imaging findings to see if the patient has chronic COPD. All right, next do the mixed pulmonary question 63. We will go over that. So, all right, so this really gets us into treatment of COPD. And treatment of COPD is by Gold. Gold came out with new guidelines, and I think it makes treatment of COPD a lot easier. The first thing you want to do is put the patient to a group. So what group is the patient in? And the group is going to rely on patient symptoms as well as patient risk. So first group would be group A. So you can see this patient's walking. Normally this patient's not symptomatic, so not super symptomatic, meaning their MMRC score is less than 0 to 1, or you can use a CAT score less than 10. CAT score is a little bit more involved, it has to actually fill out a paper. MMRC you can do, and MMRC greater than or equal to 2 is when the patient gets short of breath with walking on flat ground. So if the patient doesn't get short of breath walking on flat ground, the patient is low risk, meaning that they have had at maximum 1 exacerbation last year without hospitalization. You put them in group A. Next would be group B. So these patients may not have not been hospitalized and had less than 2 exacerbations in the last year, but they are more symptomatic. So these patients will start getting more shortness of breath with walking on flat ground. These would be group B. Lastly, C and D is now combined into group A. So anyone that has greater than or equal to 2 exacerbations last year or 1 or more hospitalization is now in group A. They're high risk, they're symptomatic, they can have an exacerbation. It's easy for me as a hospitalist. Everyone that I really get that comes to the hospital to see if the exacerbation is immediately high risk because they've now been hospitalized. They put them in group A. So what is going to be our treatment now? SABA PRN for everyone. So everyone gets the SABA as needed. So albuterol as needed. That's going to help them. They can take it. They can take it when they need, when they're having shortness of breath. They can use their kind of rescue inhaler. Different than asthma, went over asthma last time. Asthma for GINA guidelines can be ICS LABA. Here, you're really going to start with the LABA. So you start with a long-acting muscarinic antagonist, open up the airways. Someone that is a bit more symptomatic, you will add on a LABA. So you're kind of doing maximum things to open up those airways. You're going to block your muscarinic innervation, which is kind of your rest and digest response. When you're resting, maybe you don't need your long airways open as much, you're not exercising. So a LABA will cause dilation. Same thing when you're exercising, sympathetic response. You're going to need to run. You're going to need to undergo oxygen, CO2 diffusion. That's going to open up your airways. So long-acting beta agonist is going to be really helpful for these patients. Now, same thing with Group A. You're going to do a LABA, you do a LABA. But these patients, once they start becoming more symptomatic, you are going to start thinking about, do I add on an ICS? The laboratory markers that really helps you to see if the patient would respond to an inhaled corticosteroid is going to be your eosinophils. So anyone with EOs greater than 300, anyone hospitalized with EOs greater than 100, or anyone with really concern for an asthma COPD overlap are going to get inhaled steroids. So it's really been shown that if the patient has eosinophils less than 100, giving COPD patients ICS does not help them at all. It actually increases their risk for pneumonia without decreasing the risk for further exacerbation. So the EOs less than 100, don't do it. If they're greater than 300, definitely. If they're hospitalized and EOs greater than 100, definitely think about it. Definitely think about starting an ICS as well. When they're hospitalized, they might be on prednisone. So their eosinophils might be falsely low. So sometimes I will look at previous eosinophil counts if they have them in the past. For asthma COPD overlap, hard to say, but these patients might, let's say, have a little bit of reversibility on PFDs if they're FEV1. They may have history of atopy, history of asthma in the past. They may have chronic rhinosinusitis, allergies, things like that. If they have these features and there's maybe some concern, there's some asthma COPD overlap, also reasonable to give an ICS, as ICS is really the cornerstone for treatment of asthma, which is a bit more inflammatory. They're both inflammatory, but asthma, the main pathogenesis is irritant and allergen, bronchial inflammation, causing a T-cell response and subsequent, and the allergic subtype Th2 response with pulmonary eosinophils and leukotrienes. So ICS cornerstone of asthma, not as much as COPD, but if they do have exacerbations, if their eosinophils are not low, and if they have this asthma COPD overlap, you may want to add those on. All right. Next is going to be mix up pulmonary question 63. So do that real quick and let's go through it. So this starts really going into add-on management for patients with COPD. So all patients for add-on management, you're going to want to think about for COPD. One is, so anyone in your primary care clinic, so pulmonary rehab. Pulmonary rehab is very important. The reason why is that when patients have COPD, they get shortness of breath. Because they get shortness of breath, they stop exercising. When they stop exercising or they stop moving a lot, they get deconditioned, and then subsequent deconditioning increases their shortness of breath. So pulmonary rehab you're going to do for really anyone greater than mild symptoms to really break this cycle of shortness of breath, deconditioning, and worsening shortness of breath. So pulmonary rehab is huge, just like cardiac rehab is huge for people with heart failure. All big things to prevent, their mortality and morbidity, the COVID, flu, pneumonia vaccine. So definitely something to talk about at each clinic. And for gold guidelines, always check an alpha-1 antitrypsin level. And you think about people with COPD with alpha-1 antitrypsin, that they may have liver disease, that they may be younger, they may have more pan-ACR or emphysema, they may be more severe. But there is some phenotypic variant, and sometimes it can present older, and because there's treatment with giving these patients replacement of antitrypsin, you should check it for each patient, which I think is said but not always done. Lastly, smoking. So stop smoking. Unfortunately, this will decrease the progression of COPD, but unfortunately with COPD it is an irreversible and progressive disease. People lose lung function every year, whether they smoke or they don't smoke. Started I think somewhere, don't quote me, age 30 or somewhere around there. So these patients will have progressive disease no matter what, but stopping smoking can really, and the subsequent inflammatory effects and proteolytic effects can really decrease the progression of their COPD. Lastly, patients with hypoxia. So cutoff for all patients, if they have a O2 level less than 88%, or a PaO2 less than 55, these patients are going to get chronic O2 therapy. There is, so if the patients have signs or symptoms of, or complications of chronic hypoxia, so if they have an increased hemoglobin, erythrocytosis, if they have pulmonary hypertension that you really think is group 3, you can get away with giving these patients oxygen at a hypoxia level less than 89% and a PaO2 less than 59. But for all comers, it's less than 88%, PaO2 less than 55, unless they specifically talk about pulmonary hypertension and or erythrocytosis in the patient. All right, so do this one. Pulmonary mix-up, question 50. And going through this, and maybe do, all right, before we go through these, let's do a pulmonary mix-up, question 14 as well. All right, so I'm going to go through both at once because I think they're a bit similar in a way, question 50 and question 14. So once you start getting severe COPD with frequent exacerbations, these patients are likely inflamed, right? So here's a normal patient. This is nice histology, a nice bronchial. You can see the basement membrane is not super thick. There's not a ton of tissue around it. You can see that the alveolar spaces are intact. And then here's a patient with COPD, right? So it's kind of nice here that they have both subtypes. They have emphysema. So you can see that there's some breakdown here of your interlobular septa. And then when you look at when you're looking at the airways here, you can see that there's evidence of chronic bronchitis. So patients' basement membranes are increased. They may have some mucus in their bronchi. And then really here you see this inflammatory infiltrate. So COPD, especially COPD with frequent exacerbations, these patients do have a pretty decent level of inflammation going on in most cases. And like I said, for group A, if they have non-low eosinophils, that's a marker that there's some inflammation going on. But the frequent exacerbation kind of tells you that there may be some inflammation going on as well. So if someone has really severe COPD with frequent exacerbations, there's two things you can do. So, and definitely look up specific, this is kind of just general overview of severe COPD with frequent exacerbation. Just definitely look up the specific cutoffs, but one you can do is romflumilast. Romflumilast is a phosphodiesterase inhibitors. It decreases actually immune cell function, decreases cytokines from immune cells, so it decreases subsequent bronchial inflammation in patients with COPD. Maybe worse in cases in patients that have severe frequent exacerbations, so hospitalization, multiple courses of prednisone. This is something to consider about starting. And for the next question, another one you want to consider is going to be chronic macrolide therapy. So macrolides can, help decreasing, certain bacterial infections. We usually think about it for treatment for atypical bacteria, though it does cover some typical bacteria as well if they're not resistant to it. But the big thing about macrolides is that they're anti-inflammatory for really an unknown reason. So something to think about acting on and adding on in these cases as well. All right, so last question is add-on therapy. Oh, crap. I'll delete that. So